starting with the C-spine, do open mouth, work our way down, okay? So, what is it that you can recall? I know it's been a couple weeks now, but what do we recall about doing the
base of the spine matches incisors?
Yes.
Or
Okay.
base of the sacers.
So, again, I know we haven't gone over these just yet, but it's also the acanthomeatal, right? So, not too much. A little more like that. Okay, can you scoot back? Again, the closer they are, the better, right? Okay, so I am drawing a line essentially from the bottom of the nose to here, and then I can also feel right the base of the skull. Don't tilt your head. And then yeah, smile a little bit more so everybody can see your teeth. And again, you can draw that line from the bottom of the teeth to the base of the skull. Okay. All right. Don't tilt your head.
Spinal model. Not bad.
You're fine. Okay, so right now, go ahead and open up, drop your jaw. Woo, right. And then I run back and take my picture. Okay, so again, it's important to, like I said, hold your patient's head so that when you tell them to open up their mouth, they don't do this, right? And toss their head back because then your lines don't match anymore.
So we're going off of the acanthomeatal?
You can if you don't feel like looking at everybody's teeth.
Okay.
Or if they have removable dentures and they don't have teeth.
Okay.
Sometimes you need another line to look at, right? So not from the bottom of the teeth to here, it's the bottom of the teeth to the bottom of the skull. Or, right, bottom of the nose to the ear hole.
Got it.
Okay.
All right. Yeah.
Okay. So,
The
both
bottom
of
of the
those
nose
should
and-
get you in the same ballpark.
Okay.
Okay. So, and as far as, like I said, centering goes, you're going to center just below their teeth.
Oh, okay.
Okay. So
Not like the middle of the tongue?
not necessarily, because
Okay.
some people lift their tongue, some people don't. Right. So my guide, like I said, is always to go just below the teeth.
Okay.
Okay. And then, like I said, you line up your bucky and your tube. Once you find what that center point is, marker, which you didn't have today, but marker, and all the things, right?
Wouldn't you back up the tube a little bit to make up for the OID in the back of the head?
You can. Again,
Okay.
some places don't. For now, we'll just keep it at 40 for consistency's sake.
Okay.
But you could, right? And if they were laying down, obviously gravity would fix that, right? If they're standing and you have to deal with some potential kyphosis and some other fun stuff, right? So, okay. The AP is an axial. Anybody remember how far or how much we angled?
10 degrees?
10 to 15.
That was 15.
I had no idea.
I was gonna say 10, 15, got it.
So I'm gonna split the difference in M12, right? And then where do we center?
C4.
Yeah.
Adam's apple.
So the Adam's apple, slide adjustments, collimation. Now note that my light doesn't go past the chin,
Okay.
right?
Okay.
Because again, we don't, right? The mandible's gonna block anything, so we don't need to go past the mandible. And I don't need to go, right, any lower than that jugular notch, right?
Do you want them to lift their head up a little at all, or no?
Again, you're doing it very naturally, so I didn't have to tell you.
Okay.
But yeah, you would definitely look at your patient, right? But now you would too. So, again, right, that does depend on your patient.
And just for, I'm probably jumping ahead a little bit. When we actually are doing this, are we going to be doing this in an erect position, or are we going to be actually doing it tabletop?
It's both.
Both? Okay.
Yeah. So that's going to depend on where you're doing this. Hospitals tend to do most of their spines supine, but orthopedists do everything upright.
Okay.
So, again, a little bit of
You brat.
okay.
It's okay.
Any any
I
other
thought I was deleting
questions about that?
So the tilt of their head is.
So essentially, you kind of want the angle of their mandible to match the angle that you tilted your tube, which is why sometimes the Dylan has to bring his chin back down.
Oh. Okay, so 10 to 15
Okay.
degrees.
So, right, we don't have to go they don't need to throw their head back, because again, that just pulls the base of the skull back. They don't, right, we don't want their chin down, right? Just a slight elevation, like I said, you look for that angle of the mandible, should kind of match the angle of your tube.
So this one we're not lining his head up the same way, correct? Okay, got it. And right doesn't go past chin.
No. Okay. Okay. Any other questions about this one?
Negative.
Okay. Now we get to the real fun part with the obliques. Okay?
He knows.
Good patient.
He's done it
It
before.
does, yes. All right. So not that far. Come forward a little bit this way. Okay. And then, right?
And this one we're looking at the right joint,
Yes.
because I remember your thing.
It's the upside. Okay. So, if we are going to be doing the right, so what position is he in?
Left
LPO.
LPO.
So this is the posterior, what they consider posterior obliques, right? Based on the position.
Do we use the right marker for this?
Yes.
Oh.
You're looking at the right side.
My brain does not like that.
You might directionally challenge.
Oh.
So,
Yes.
That's what you're looking at.
can you put the left marker though, because you are still putting him in the LPO
That's
position,
what I
as long as it's in the
Yeah.
opposite side.
So again, right? There are the two conventions. I'm gonna borrow your
Yeah.
markers real quick. Okay. So.
That's what I would want to do.
That's where I will get the repeat, because I'm gonna want to put it on the left
Okay.
side.
So, right, again, yes, you can put it on the left as long as it matches, right, the patient's left.
Okay.
Okay? What you cannot do
Just put it on the other side.
is that.
Okay.
Okay? Because again, we have crossed the spine
Right.
onto the other side. That is no longer the patient's left side.
Yeah.
Okay?
But as long as we keep it on the left side in this position, we can't put the left
I don't
marker.
re- I cannot remember what they did at the hospital.
So, yes, it's not incorrect. However, it's confusing, right? So, it's confusing for who reads it.
Okay.
Okay, so this is why, right, I like to stay consistent and put the right marker, right? So there's a couple of reasons why I put, okay, but let's sit down, but why would I wanna make sure I put the right marker in the right upper corner?
Get out of the anatomy. Stay out of the anatomy.
It's also telling the patient, or the person reading it, that the right side was up.
Right side was up. Okay. mark
So
it.
I am
Ah.
also giving them a, right, that, like they're looking at the right zygapophyseal joints, and right, putting it in the top corner, letting them know right side was up. Okay? So that's,
So, just out of curiosity, if we were doing an RAO for the same for the same viewing, would you then put the marker on the right side down?
yes.
Okay.
Wait. Okay. So then this
Well,
one I would.
I'll show you those in a minute.
No. I'm sorry. This one to the left. If I was gonna mark it for the left, I would put it down there. Okay.
Yes. All right. You keep me. Okay? So those would be the two, right, marker placements if we were doing right under.
Do you have any tips for getting that 45 with the body perfect?
You actually don't do 45 with the body. So you do more like 30, and then you finish the 45 with the head,
Okay.
right? So you're thinking about getting, like I said, the neck. So this area 45, not necessarily this
Oh,
area 45,
Gotcha.
right? So it's a little tricky, okay? So, like I said, we do the body at about 30, and then we do the other 15 with the head. Okay? And like I said, you're gonna follow this. So he's not centered, right, where I want him to be. Not that way, this way.
Okay.
And then this time I need to make sure that I move my centering up, right? Because now I need to get needs to sag. Right, this time I do need to get all the way up to the EAM, because that's C1, right, and down, right, to the jugular notch. So, right, going above that, right, Adam's apple to C4, right, instead of C5, where we were before.
You're slightly above the Adam's apple, correct?
Yes. Okay. So this would be, right, my posterior oblique position, but anterior to posterior projection for the right intervertebral foramina.
And you're still at 12-degree angle?
Yeah, I kept it the same
Okay.
as I did for my, but they should somewhat be the same.
Okay.
So the
Although
AP,
you can do 15 to 20, right, that's also.
so for the AP axillary and the obliques, they're both at about between 10 to 15 degrees.
More like 15 to 20, but yeah.
Okay.
Okay.
It's 15 to 20.
So-
And if you did this the other way, you would angle caudal the same degree.
Get there, don't.
Sorry.
Just hold your horses.
Yeah, chill, man.
There's a couple of things that change when we switch to doing posterior
Holy cow.
projections, okay? So, right, we have to do the other side. So this always gets a little bit of a tricksy. Right, because when you switch sides, patients don't act the same, right, on the other side. Okay? That's not too bad. Okay. So again, notice how I switched my markers. Left went up, right went down,
Okay.
right, as I switched sides. Okay?
That's actually smart.
So, again, keep tilting your head. So. And still follow the muscle, right? That's gonna be your center point. You can also think of it as, right, following that EAM, right? If it's hard to see or feel the muscle. Okay? Alright, so again, this is posterior positions, AP projections for the oblique C-spine. Okay?
And you always do these in pairs
Yes.
together?
You're always going to do a right and a left. Okay? Now, if I wanted to still focus on, right, I'm doing the left, right, intervertebral foramina. What anterior oblique position is the same, right, in this case?
LAO.
Very good. Okay, so you're gonna flip all the way around. So left is gonna go against the board. Okay.
Mhm.
Again, that muscle now, so that position we literally kept in the same. So the same right twist of the head. I have just flipped them backwards. Okay.
I like this one better.
So that's
The marker
LAO.
makes sense.
So this is LAO, right? It was the same as the RPO that we just did, okay? But now I need to switch my markers, okay? So left is down, again, right
Right is up.
is technically up, but
But this one we're showing the left joint. So we
Yes.
wouldn't use the right one at all, correct?
again, you never know.
Okay.
But if people had to, that would be the direction. Now this is what should, okay? So now you also have to go 15 down.
So, PO's 15 degrees cephalic. AO's 15 degrees caudal.
Wait a minute.
Okay, and then I have to pull you back. Okay,
It's over here. Flip it around.
okay.
Yeah.
So, right, again, this one's a little bit tricky because we don't have that same trick to be able to line up with the ear hole, because we're trying to line up with the ear hole that's closer to the IR. So you're gonna go behind the one that you can see, but you also wanna double check, right? Kind of looking from the front. Right, to make sure that this matches. Okay. Yes?
Where's it centered at? This one?
It's still gonna be right C4 as we come out to this side.
Okay, just because the angle looks. Yeah. Okay.
So the angle position from the tube will be centered more around maybe C2, but as it comes out to hitting the IR, it's coming out C4.
Correct.
Okay. Are you gonna tell us which one that we're gonna do for this one? Like, or someone else
Just do
can do
all of
AP and someone else can do PA? You trickster.
I vote we all do
Okay.
PA. I mean PO. Just automatically PO.
Steer. Oh wait, no, this is
We're
it.
gonna do 'em anyway.
This is it. Anterior oblique.
So this is an LAO position,
Yeah.
right? To still see the left, right, intervertebral foramina. Again, we have a caudal angle, okay? Again, still exiting, right? Center should exit C4, just like it entered C4 on the other one. Now it needs to exit C4, because again, we have literally flipped everything around. Okay? So,
Okay.
now we're going to do,
The lateral.
nope, the other oblique,
Oh.
because these come in pairs. So if I showed you the LAO, now I need to show you the RAO, okay? So, yes, doing good, but step forward. Oh, there we go. Okay. So, right, again, all things being equal, that should be the same, right? Okay. So, I know these are, right, nobody's favorite, okay? So the last one, let's go ahead and do your lateral. So turn back towards me, so your left side's up against the board. Okay, relax. So this one back, chin down.
Sorry.
No, you're good. You're
Okay. Michael, watch out. I'm coming back towards you because I gotta get to 72.
Odd one, 72.
What's the figures on this one? Okay.
You can shoot the obliques at
Some
72
gatekeepers.
too, right?
Yes, you can.
I can get people.
So what's a good like workflow
Oh, no,
for
no,
that? I think
no,
it's
no.
better just to do
Oh,
this
I
and
know,
then
I
do
know.
the obliques, you have to move it, or?
Yeah. So if you're gonna do your obliques at 72, then I would start with the lateral. That makes more sense to me, right?
Okay.
Did you guys do obliques at job?
And it's something
Yeah.
like that,
Yeah.
Yeah.
like the laser pointer on the wall.
Okay.
I feel
So
like they use
this
them all
would be
anterior obliques so that, you know, to reduce patient dose.
Okay.
They're all about that.
and I probably put that down there. Okay.
The marker's always on the bottom right corner anteriorly?
Not necessarily, but
Okay.
there's a space there,
Okay.
so it makes sense to put it there, right? That way I'm not in
You're not-
confusing it, right?
Also, if you do your AP, you just leave it there too. So you can kind of just, as you transition, just keep your left up.
Yes. In this case, that does still work at this station. Not all stations are gonna have the left as the working side when you're, so, just careful, right? So, again, this, right, this patient, you have to really work on making sure that they don't tilt to the side a wee bit.
And I filtered too, don't worry.
Yeah.
I'm like that too, don't worry, yeah.
I know, I find myself doing it too, and I'm more like really aware of it because of my mom. So she always leans to the right. I find myself always kind of leaning to my left. Like that's my,
Oh,
I
yeah.
relax to my left, and I'm like,
No nerve neck.
yeah. So I'm like, no. Anyways, okay. Questions about the C-spine?
We are not gonna be shown swimmers?
Good question.
Could you show us the
Oh, that's
swimmers
right.
really quick?
Put that on the T-spine. Okay. So, while we're up here, I guess we can do that. Okay, go ahead and lift up your left arm for me. Okay.
Or do you want more of like a head hold? Is it easier?
Okay,
Nice patient.
so we'll lower this down exactly, right? So this crease is kind of what we're going for, right? So specifically the swimmers is supposed to be for C7, T1, right? So if I find that jugular notch, like I said, I'm a bit above that, so that should be where we're going. Do you have to
Above the
match
jugular
this, so watch out. Okay, and again, try not to have any weird rotation, okay? So, what I can also do is put just a slight, like 5-degree tilt.
5-degree coddle.
Even with the arm lower, you would still put the caudal on
He
it.
probably wouldn't,
Okay.
He's
cause
really
he's
doing
really
this.
got it, but if like you don't see much of a change in their right shoulders,
You-
a little more.
Okay. So it just all depends on the patient.
Mhm.
Okay.
It does,
Okay.
okay? But that's, like I said, not too much, okay?
And is that only if you don't see C7 on the lateral? You switch to, you will add a swimmer's in? Or do you?
Yes, for
Okay.
both the C and the T spine laterals. Okay?
So question, if you're doing the lateral C-spine, and again, you don't see C7, couldn't you just put a little bit of a caudal angle on the lateral? Or maybe a couple degrees?
You're
and-
gonna repeat that anyway. Watch out.
Sorry.
But you again run into the potential issue of the clavicle, right?
Okay.
At the downside. So by putting the arm up, you're right
Moving the
pushing
clavicle.
that
Oh,
out
got
of the way,
it.
right? So, while we're here, we might as well do the lateral T-spine.
Shimmers, obliques.
So I need to change this. So again, smaller IR.
For C-spine.
C-spine,
You can keep it at a 14 by 17 IR.
yeah, if that's all you have, then,
Means what do you
yeah. Thank you.
You're welcome.
And the swimmer's views are still done in a portrait. They're not done. Okay.
We're not doing T-spine obliques?
No,
Very good.
because again, we don't ever do those, no. I'm not gonna worry about that, like I said,
Cool,
you
yeah.
know it, but you're not gonna do it.
Yeah, one of the techs at the ortho office, they get all the spine stuff. She said she's only seen that one time by one doctor
Why?
ever.
Yeah,
Is that what you asked? Why?
why we're not doing the obliques?
No, why don't you see it a lot?
Cause it's a really hard view to still see,
Uh,
right? So most doctors find it less informative than more informative.
okay.
Because you have all the
You have
tissue
all
of
the
the mass.
ribs, you have all the other stuff that are, yeah. Okay, so back to T-spine. Again, T-spine can be done at 72, it can also be done. Wait, I might have to turn the lights off because it's really hard to see.
Here, I'll turn them off.
You get more, the purpose of doing the 72 is to put your feet
Um,
towards so.
kind of. Less magnification as well,
Okay.
because you also have a significant OID. But there's nothing that we can do about that, right? So,
Dylan's doing the A of the
What'd you do,
YMCA.
Mm-hmm.
Mm-hmm.
Why'd you put your hand on his back like that?
this?
No, you were like this on his back, right?
On my midline, maybe?
Yeah.
Um,
That was.
Trick of the trade.
Hey, man, I'm trying to take as many tricks as I can.
That's true. Alright, so, you see a little light back there. Right, I don't have to see right, the full light back here,
Mm-hmm.
okay? Because again, we still have muscle and tissue, right? The bone is gonna be a little deeper than that, so we should be okay here. But you do wanna, like I said, one of the curvatures, you should have a little pocket of light, okay?
So, we would need to have the top of your light at least at like the vertebral prominence, right?
It's the top of my IR is at the vertebral prominence,
Okay.
yes.
Okay.
Okay,
Is it like the centering of the chest lateral?
yes,
But more forward, right?
yeah, exactly. So for a chest lateral, you're trying to, right, be a little bit more midline. Like I said, I am purposely moving them forward
Right.
in order to focus on the spine.
You're like slightly rotating him left, or to see the light behind you said, or?
No, I'm pushing them forward to see the light, okay? So again, you can't see it back there, you can only see it back here. Yeah, get out of your chair, Xavier, come on.
It was coachable.
He was really comfortable.
So this little
Oh, that's what you
corner
meant.
is what I'm talking about.
Oh.
Okay?
Oops.
Snip.
Sorry.
Telling.
That was me.
Ruined my whole thing. Okay, so, like I said, still, right, that same center that you do for a chest, right? But you are, like I said, moving them forward to make sure you see that little sliver, right, back there. Okay, any other questions about the lateral T-spine? Okay, AP. Again, I'm gonna come into 40, watch your feet there. So, same centering, right? That part shouldn't have changed, okay? So I shouldn't have to readjust that. And again, really relax those shoulders. If our light was a wee bit better, you would see, right, that corner light there. But you do have light, right, just above the jugular notch. Same sort of thing here, you can see it past the xiphoid. So again, you know that you're, right?
It's almost to like the rib margins then, right? For the bottom border?
Yeah, so if I push in, right, bottom of Dylan's rib should be right about there, right? That corresponds to the bottom of my IR, right? It's not necessarily the bottom of my light, it's the bottom of my light once it gets diverged, but I can't see that, right? When I'm looking from the front, okay? And that same thing goes for up here too. It's like you don't see it past your shoulders, but it does go past your shoulders, you're gonna be fine, okay?
And for the tight collimation, would it be a good rule, just be the girth of the neck?
I see what you're
Yeah,
Okay.
That's a good.
Yeah.
Looking at that.
talking about.
But if you suspect scoliosis, you might
you might
want to
go
be a little wider.
right?
Go two, right? Go this way. No?
Huh?
Just do 17,
Not the two,
17.
no, you would,
Yeah.
if you expect scoliosis, you would just
Oh,
open this up.
I see what you're I thought, yeah. Scoliosis this way.
Let's do the whole
Yeah.
thing.
Yeah, do an AP chest basically.
A little bit extra.
Go all the way back to 100 and then just open it up the whole way, as wide and as long as you can. You'll get it every time.
Give them their money's worth.
Oh dear, okay, so, like I said, this is your
Half the
AP.
time, it works every time.
Okay, questions about any of that?
Negative.
Okay, then you're on your own.